This video describes what I, as a statistician, typically look for as I read a manuscript describing a randomized trial. I'll use it as an example the randomized trial of tonsillectomy for childhood sleep apnea, reported by Marcus and colleagues in the June 20th, 2013 edition of the New England Journal of Medicine. If you haven't done so already, please read this manuscript. The first thing that I'll read is the abstract. This particular abstract uses a standard format of background, methods, results, and conclusions. The background section of the abstract should describe the main study question and why it's important. I try to put these two things into my own words. For example, for my reading, the study question is whether or not children with sleep apnea should have their tonsils removed. The reason that the question is important is while doctors often perform this procedure, they don't have definitive evidence that it works. Obtaining this evidence is important. Otherwise, children will have been needlessly exposed to the risk of surgery, and their parents will have to pay its cost. Even at this early point in my reading, I might need to find out some additional information about sleep apnea, why it's bad, and how tonsils are involved. Wikipedia is a good place to start. Try to summarize things in my own words, and ideally, I might try out the results on a doctor or another colleague. Here's my attempt. Sleep apnea is an involuntary pause in breathing, which is self-evidently a bad thing. In the extreme, apnea can lead to cognitive and behavioral deficits, which I presume are caused by either the lack of oxygen to the brain, getting a poor night's sleep for lots of nights in a row, or both. Sleep apnea is caused by the obstruction of the upper airway. Enlarged tonsils can cause such an obstruction. Doctors hope that removing a child's tonsils will remove the obstruction and thus eliminate the cause of the sleep apnea. But this surgery has risks and thus should only be performed for a good reason. Taken as a whole, the above constitutes the biological rationale for the study. The first paragraph in the introduction section is consistent with my understanding of the biological rationale. The next part of the abstract is the method section. I'm looking for four things: the population of interest, the study groups, the follow-up period, the measurement schedule, and the outcome variables. Here, the population of interest is children with obstructive sleep apnea syndrome. The study groups are surgery and watchful waiting. The follow-up period is 7 months. The outcome variables can be classified as polysomnographic, cognitive, behavioral, and health outcomes. For now, I'll make a mental note that I don't know what polysomnographic means. In fact, I'm not even sure I can pronounce it, and that I'll want to check on this if it isn't clear from the body of the manuscript. The next part of the abstract is the results. In general, I'm trying to distinguish the results for the primary outcome variable from those of the secondary variables. Although there's more to the results than statistical significance, this is where I usually start. From a quick reading, it appears as if the surgery didn't have a statistically significant impact on the primary outcome, but did improve a number of secondary outcomes. The final part of the abstract is the conclusions. As a reader, all I'm trying to do is identify the main message of the manuscript. Here, the main message appears to recapitulate the results with no additional interpretation or recommendations for action. Continuing to the main portion of the manuscript, in the introduction section I'm looking to verify whether my initial impression from the abstract is correct. Specifically, like the background section of the abstract, what I expect to find is the study question and the reason that it's important. It's quite possible that I'll need to look up some medical terms. For example, looking at the second sentence in the introduction, I might have to find out that adenotonsillar hypertrophy means enlarged tonsils. I also noticed the rationale for making attention and executive function the primary outcome variable. I'm not quite sure what attention and executive function means, but do know it was selected as the primary outcome variable because it's sensitive to hypoxemia, that is, to too little oxygen in the blood. Hypoxemia is caused by breathing difficulties, of which sleep apnea is an example. The introduction section also mentions that the hypotheses will include subgroup analyses, specifically whether the efficacy of surgery will differ by race, weight, or baseline severity of sleep apnea. Personally, I don't find the argument performing these subgroup analyses to be particularly compelling. For example, the authors mention that sleep apnea is more prevalent among obese children, but didn't explain why surgery would be more or less effective for them. The method section of a randomized trial is usually divided into subheadings to make things easier to read. This manuscript is no exception. Under study design, the first paragraph says the trial was performed at 7 academic sleep centers and is singly blinded. Blinding is a way to reduce bias, and in this case means that the personnel who collected the data didn't know which group the patient was assigned to, and thus couldn't influence the results. Blinding isn't always possible. For example, this isn't a double-blind study because patients knew whether or not they received the surgery. The fact that the study was limited to academic sleep centers might limit the ability to generalize its conclusions. The second paragraph of the methods lists the inclusion and exclusion criteria. Looks to me as if they are targeting children with moderate levels of sleep apnea. You'd have to be an expert in sleep apnea to determine whether these criteria are clinically appropriate. If I were designing the trial rather than just reading about it, one of the questions I'd ask the other investigators was what type of patient they're trying to target. For example, someone with chronic or acute problems, someone with mild or severe problems, and so forth. Then I would ask whether the inclusion criteria are consistent with their intentions. As a reader, I usually don't pay much attention to the verbiage about study oversight, since verifying that the oversight is appropriate is part of the review process. As an investigator, I do pay a lot of attention, however, since this is one of the criteria for ethical statistical practice. The paragraph about assessments wasn't sufficient to tell me what polysomnographic testing meant, so I looked in Wikipedia, and according to them, it's a sleep study where the patient is wired up, and what is reported is various physiological changes that occur during sleep. The first paragraph of the outcomes section induced a quick search on the NESB. It turns out that the primary outcome measures things like attention and how effectively the child thinks. As a statistician, I want to know whether the instruments used in the study have good measurement properties. The reference to good psychometric properties in the text of the report is reassuring. The second paragraph of this section describes the secondary outcomes. At the very least, I'm trying to discern the scale of measurement. For example, most of these outcomes are continuously scaled, the possible values, and evidence of good measurement properties. A statement about what differences are considered to be clinically significant is a plus. Often more detailed information is provided about the primary outcome than for the secondary outcomes. In the statistical analysis section, I'll start with the primary hypothesis. There are two main ways that two groups can be compared, and indeed many studies use both ways. One approach is to compare the groups directly, that is, without including any other variables in the analysis. The other approach is to compare the groups after accounting for covariates, in other words, by including other variables in the model that might matter. That's what the authors did here, using the analysis of covariance. Finally, additional comparisons are made, such as subgroup analysis and our test for interaction. In either case, what the authors are trying to do is to determine whether the impact of the surgery is the same for different subpopulations. Here they decided to perform the assessment using interaction terms. Perhaps precisely what an analysis of covariance entails and what an interaction means is discussed in another module. Power calculations are used to justify the sample size. Typically, they're based on the main analysis, the primary outcome variable, perhaps on a simplified version of that analysis. You need to know the statistical test that will be used for this analysis. This in turn depends in large measure on the scale and measurement of the variables that are used. Once you know the test, you know its key inputs, which are key things that must be specified. In general, I'm looking to see whether these key inputs were specified, and if so, whether or not they are reasonable. Here the power calculation is based on specifying a generic effect size of 0.32. For now, I'll simply comment that the power calculation appears to be technically correct, but that an input of the generic effect size seems rather weak. Power calculations will be discussed in detail in a later module. Moving to the results section, Figure 1 is called a consort diagram. It describes the flow of study enrollment, randomization, and retention. As a critical reader, I'm looking for a number of things. If lots of patients were excluded before randomization, the patient population might be highly specialized, and thus the results might not generalize. If lots of randomized patients don't receive the proper intervention, this will reduce study power by contaminating the groups. If lots of patients were lost to follow-up, the results might be overly optimistic, especially if the patients that were lost do less well than the patients who were retained. Finally, if there's differential dropout between the groups, I particularly worry for the reasons that were previously noted. In this study, there seemed to be a lot of attrition before randomization, but relatively little after that. As far as this attrition is concerned, I feel pretty good about the internal validity of the study, but perhaps less sanguine about its generalizability. As is typical, Table 1 describes the baseline characteristics of the two study groups. I didn't expect to see any differences between the groups, and none were found. Nevertheless, it's important to check, as randomization can go wrong in any number of ways. Fortunately, that isn't a problem here. Clinical readers might apply an additional criteria to Table 1, namely whether the descriptive statistics in that table describe a patient population that is similar to those that are of interest to them. For example, are they like the patients they see? One thing that might be of interest to a clinician is the observation that the cognitive and behavioral scores are near the population mean. In other words, it doesn't look as if sleep apnea has caused long-term harm to the children being studied. This would make me wonder whether this study has a ceiling effect. In other words, as far as the primary outcome variable is concerned, the children might have relatively little room to improve. Table 2 summarizes the study outcomes. As a statistician, I'm looking for statistical significance, magnitude, precision, and clinical significance. For example, the NESB score improved by 7.1 units in the surgery group and 5.1 units in the control. The magnitude of this difference is 2.0 units. The difference isn't statistically significant, as illustrated by the p-value of 0.16. The standard in trials is to report precision through a confidence interval of 2.0 units plus or minus a certain amount, and failure to report such a confidence interval is a limitation of the manuscript. Nor is the reader told whether 2.0 units are clinically important. This table also illustrates the importance of randomization. Outcomes in the watchful waiting group improved, and a study that didn't include this control group will have wrongly concluded that surgery is effective. The results section included various analyses of secondary outcomes. The direction of the effect was almost always in favor of the surgery, but it wasn't always statistically significant. There's more to the results section than statistical significance, as noted previously. One of the next steps for a statistically significant finding is to determine whether it's clinically significant. The ideal is to have the results be consistent in direction. That holds here. Surgery works better than watchful waiting for all the outcomes. You want them all to be statistically significant, which doesn't hold here. Some but not all the outcomes are statistically significant. You also want the results to be clinically significant. And that's difficult to ascertain here, because the criteria used to determine clinical significance, namely effect size, is generic rather than specific to sleep apnea. Overall, I would judge the results as moderate to strong evidence that surgery is superior to watchful waiting. The results section also includes subgroup analyses. I don't always take subgroup analyses seriously because of two statistical problems. The first problem is induced by the large number of comparisons. The more you look, the more statistically significant problems you'll see, even if there isn't anything real happening. This is sometimes called the multiple comparisons problem. The second problem is that subgroup analyses are often underpowered. The reasons why will be discussed in another module. But the implication is that negative conclusions might be false negatives. In other words, finding no difference in the efficacy of surgery by race provides only weak evidence that race doesn't matter. Overall, it seems like a modest level of evidence in favor of the idea that the impact of surgery depends on subgroup being studied. Neither study group had large numbers of adverse events. That was encouraging. Many but not all of the discussion sections follow a standard format. It begins with a summary of the important results, proceeds to discussion of limitations, then interpretation, then conclusions. Often the conclusions are tied back to the rationale for the study question. Here, for example, a natural conclusion would be a recommendation for whether or not the surgery should generally be performed. Here the authors shied away from making such a recommendation. As a critical reader, I pay particular attention to whether the discussion of study limitations is reasonably comprehensive, which it appears to be.